Learning Plan 3 is focusing on managing care for patients experiencing mood disorders. So we first start with Chapter 13 when we're looking at bipolar and other related disorders. So the clinical picture that we're looking at, we're really thinking about three specific disorders here: bipolar 1, bipolar 2, and cyclothymic disorder. You may have heard of bipolar 1 referred to as manic depressive disorder. That is an old term, so we don't call it that anymore. But basically, that's what it is. People have periods of depression alternating with periods of mania. So, anyways, bipolar 1 is the most severe form. It has the highest mortality rate or death rate of the three types. And in order to be diagnosed with this, you have to have at least one full-blown manic episode. So it is not the same, full-blown manic episode is not the same as being hypomanic. So I'll talk about that in a second. So that's what it takes to be diagnosed with bipolar 1. Probably in the hospital, most of the patients that we see are diagnosed with bipolar 2, but we do see bipolar 1 every now and then. But that is the absolute most severe form of the disorder. And along with, it doesn't say on this slide, but along with, obviously, to be bipolar, you have to have, your mood has to fluctuate between those two different poles. And those are polar opposites of mania and depression. You have to have at least one manic episode, but you also have to have an episode of depression in order to carry this diagnosis. Bipolar 2 is at least one hypomanic episode and at least one major depressive episode. So hypomania is different from mania in that basically the symptoms are very similar, but they are less severe. So a person with hypomania isn't going to display quite the same intensity of symptoms. And we'll look at those, the symptoms more specifically in some future slides coming right up shortly. But anyways, so bipolar 1 and bipolar 2. The other mood disorder that we're talking about in this chapter is cyclothymic disorder. And basically that is alternating symptoms of mild to moderate depression for at least 2 years. Oh dear, I'm seeing a couple of little typos there that I missed when I was redoing these. But anyways, so it's alternate, not alternate, and symptoms of mild to moderate, not mild to moderate. Oh my goodness, I'm going to have to fix that. Anyways, for at least a two-year period. So that's the thing that's most important to remember about cyclothymic is that they really have very, much milder symptoms. These patients may never even be seen in the hospital. They're more likely to be cared for on an outpatient basis. And truly, 2 years of having these cycling episodes of mood changes is really quite a long time for somebody to be suffering. Many times, though, people with cyclothymic are able to carry on their day-to-day life, but they may just not be able to be quite as maybe as functional and productive as they would be if they didn't have a mood disorder. So that's what cyclothymic is. There is rapid cycling also that is possible with bipolar disorder. And people that have rapid cycling really have very rapid changes in their mood. Some patients, it really varies quite a bit. Some patients can have changes within hours, days, weeks, just many, many times a year that they're alternating between periods of depression and periods of mania. So epidemiology, up to about 21% of patients with major depression may actually have undiagnosed bipolar disorder. These mood disorders are really very difficult to diagnose sometimes because there isn't a specific blood test that you can take to find out which mood disorder you have, or if you have schizophrenia. There just isn't a blood test for that like there are for some medical problems. So it really is difficult to diagnose. You really have to go by the history, the symptoms that the patient complains about, or perhaps that the family complains about. And really, sometimes patients have to be kind of carefully assessed over time in order to figure out the most accurate diagnosis. Bipolar 1 just happens to be more common in males. Bipolar 2 is more common in females. And cyclothymia usually begins in adolescence or early adulthood. A little bit of a case study. Ms. Adams, 53, has just been admitted to your unit with bipolar disorder 1 and is in a manic state. What symptoms might you expect to see? Well, we haven't really talked about symptoms yet, but one of the choices would be A, catatonia, which basically is being pretty much mute, not talking, not moving, not communicating, not responding whatsoever. B, expression of racing thoughts. C, low self-esteem and tearfulness. And D, lack of interest in her environment. So I'm hoping that you maybe guessed that the correct answer would be B, expression of racing thoughts. If somebody is in the manic state, they would not be catatonic. That would be more of a people can be in catatonia when they have schizophrenia, or perhaps when they are depressed. Low self-esteem and tearfulness, depression, lack of interest in environment could be. It sounds to me more like depression. Could be a little bit of anxiety, but more of a depressive symptom. So really the only one out of these four would be the racing thoughts. That would be one of the symptoms that we're going to see in mania. So some of those symptoms then include extreme drive and energy, having an inflated sense of self-importance, drastically reduced sleep requirements, and that doesn't mean that they actually can do well on a little sleep. It means that they really don't think that they need much sleep and they don't get much sleep. They will say things like, oh, I can get 2 hours of sleep and get so much done. Well, that really isn't good for their body, whether they think that it's okay or not, or they think they're doing great because they have all this energy. Their body actually needs sleep. So one of the things that's interesting about having a patient in a manic state is that we really do have to monitor their physical status very, very carefully. So it's not just their mental status. If people are not sleeping and they're in a manic state and they are constantly on the go, it's very hard on their cardiac system. So people can actually die from lack of sleep and also from the excess stimulation. So we really do have to think about their sleep as being an extremely important symptom. Matter of fact, that's one of the symptoms that we usually teach patients, that if they are home and they are noticing that their sleep is getting worse, that they're sleeping less and less, that they probably should talk to their doctor right away, because that is one of the main symptoms that we're looking for that might signal that they are going into swinging back into the manic phase of their illness. So it is a very important symptom for us to be looking at. Excessive talking combined with pressured speech. So when somebody has pressured speech, it is really hard to get away from them. They may catch you in the hallway. You might not even be assigned to them during clinical, but they're going to catch you in the hallway and they're going to be talking to you and talking and talking, and you're going to feel really rude saying, I'm sorry, I have to go now. I have to do something. I have to check on my patient, or I have to give my medications, because they're not going to want to let you go. They're just going to keep talking and talking and talking, and they are very difficult to get away from. They have feelings of racing thoughts. They have distraction by environmental events. It is interesting if you're, again, talking to somebody with mania out in the hallway, and just the number of things that they're distracted by in the middle of your conversation. They really can't stay focused on their conversation. So in a way, the distractibility is a good thing, because if somebody gets irritable or upset about something, you can always use that distraction as a way to kind of divert their attention off of something they might be angry about. So that distractibility actually can kind of work in your favor as a nurse from time to time. Again, if they're really feeling irritable about something and it's maybe just not an issue that's going to get easily resolved in the hospital. They're unusually obsessed with and over focused on goals. So I had a patient once tell a student that they had, 3 books and 6 magazines that they were all reading at the same time, and they had all the pages open, all and the books and magazines spread all over their bed, and they're just very focused on their goals and very, obsessed about completing things. They have purposeless arousal and movement. So sometimes pacing is a huge symptom that we see. We see pacing in a lot of different illnesses. Many people with schizophrenia also do a lot of pacing. And even sometimes people with depression and anxiety can pace if they have kind of some motor restlessness symptoms. But many times people really, in a manic state, really have a lot of purposeless arousal and movement. They're just constantly needing stimulation and they're constantly moving around, not always accomplishing something. They do engage in dangerous activities such as indiscriminate spending, reckless sexual encounters, or risky investments. So they can get into a lot of trouble. There was a patient a few years ago who actually bought a, I don't know, $40,000-$50,000 truck when they were in a manic phase and then really couldn't pay for it. They were in the hospital and they actually asked the doctor to write a note to the car company, to the car dealership saying that they bought that car when they were in a manic state. I think they were trying to get out of paying for the car, but that doesn't work. People do have to remain um, responsible for their actions. And I'm hoping that perhaps maybe they could have sold the car or done something perhaps with that dealership, perhaps sell it back, but they certainly aren't going to get out of paying for a car just because they bought something in a manic state. So that's the part of being manic that's kind of difficult sometimes because they do get into some really, really difficult behaviors with spending money and again, relationships. They might have an affair if they're married, and just really their behaviors can just absolutely wreak havoc with their life, and with their relationships. um, and their money. They can end up really in quite a bit of debt because of their manic behavior. But they do remain responsible for their behavior, but it is really difficult when somebody is a manic state for them to truly understand what they're doing. They truly don't have any insight into what they're doing, into the consequences of their behavior. And that's part of what makes this disorder so very, very difficult. Little case study. An assessment interview reveals that Miss A is a Miss Adams, I think her name is an adjunct college English professor who has published 2 novels and is working on a third. It was almost inevitable, she says, because I grew up in a family of 5 anxious girls with competitive, ego-driven professional parents. It was hellish. I found escape in writing stories and putting on plays with my sisters. When I got a scholarship later, I practically ran away to college, where I absolutely lived on coffee, books, and the drama department. Miss Adams further describes her childhood, a part of her life she finds particularly troubling. We all had to compete if we wanted attention. Dad played favorites depending on our grades and talents. I was his favorite, but I hated it because it made my mother hate me. How could she compete with her own daughters? Sometimes in high school, I scared myself with how much I just wanted to hurt them both. I decided I would never marry and have kids. So, based on her history, which factors can you identify that may have an influence on Miss A's condition? Biologic factors, psychological factors, environmental, or all of the above? So I'm hoping that you picked all of the above. It's very possible that she has a biological family history of mood disorder. It sounds like she had the environment, it sounds like was a very dysfunctional type of family, and all of the psychological stress that her parents put on her. So all of the above really would influence, not necessarily cause, but influence her condition. So we're looking at assessments. We're looking at mood, behavior, thought processes, speech patterns, and cognitive functioning. So speech patterns, we have pressured speech, circumstantial, tangential, loose associations, flight of ideas, and clang associations. So all of those things are speech patterns that you're going to be seeing in people that have mania. Describes these really well on page 229. So pressured speech, again, fast, really hard to get away from that person. They're inappropriate, have an inappropriate sense of urgency. And I really love their description in the book. It says, if normal speech is analogous to the flow of a garden hose, pressured speech is like the stream from a fire hose. So that is just absolutely an excellent description of what it's like when you have pressured speech. It just blurts right out of them. Circumstantial speech. So that is used when people are adding unnecessary details when they are communicating with other people, and they eventually get to the point. But it's to me a good. They give kind of a nice example in the book, a little paragraph, but a really succinct way to think about circumstantial speech is you ask somebody what time it is and they tell you how the clock was built. So they're telling you all kinds of extraneous detail that don't even necessarily relate to your question, but they eventually get to the point. Tangential speech is kind of similar to circumstantial, but they don't ever get to their point. So the point is just really pretty much lost. And so they kind of start talking about something and they go off on a tangent and they really never get back online to what they were talking about. Loose associations is something that people do. Well, we can all do this a little bit. You start talking about something and it reminds you of something and you kind of go off a little bit, and it's kind of loosely associated to what you were talking about, but maybe not not super relevant. So your book gives an interesting example of what a patient may say. The sky's the limit. Now that I have money, I took a flight. From Kennedy, drinking beer is a belly full of bags. Okay, well, that's an interesting loose association. Part of when we're assessing speech patterns, part of the problem is that many times these abnormal speech patterns makes it really difficult to understand what a patient is talking about. So it really is challenging to figure out what exactly they're trying to tell us. So one of the main things that we can think about when we're communicating with people who have these disordered speech patterns is to look for a theme and try to look for like the feeling behind what they're saying, because sometimes if we focus on the content of what they're saying, it doesn't always make a whole lot of sense to us. But if we kind of pick up on themes of fear, anxiety, sadness, happiness, anything, just being upset about their future or worried about their home life, whatever theme we can kind of pick up on is a really good way for us to try to communicate with people with these disordered thought processes and speech patterns. Okay, so that was loose associations. Flight of ideas is a continuous flow of accelerated speech, and they just change from topic to topic to topic. And unlike loose association, there really isn't anything to even, at least a loose association, things are loosely connected, so you can kind of see a little bit where they're going and why they jumped from this to this. But with a flight of ideas, it is really difficult to understand what they're saying. And it may be absolutely disorganized and incoherent to the point of you truly don't know what they're talking about. So again, listen for themes and listen for the feeling, if you can, the feelings that they may have behind their words. They might also do a lot of like joking, puns and teasing, things like that. So those are always things that we have to respond professionally to, and that we can't joke and tease back because that just really isn't really helping the situation at all. So flight of ideas very challenging. Clang associations is basically stringing words together based on their rhyming sounds, not without regard to their meaning. Okay, thought content now is what actually they're thinking about. They may have grandiose delusions or they may have persecutory delusions. So people that have grandiose delusions really think they have a very highly inflated self-regard. So they may exaggerate their achievements or their importance. They may state that they know famous people or believe they have great powers. I have seen every one of those symptoms in clinical. I have seen patients state that they are God. I have seen patients state that they have a medical degree and that they're also a lawyer and they know more than the doctors and they know famous people and they'll name drop and list off a bunch of famous actors and actresses. And it's just absolutely not true. So they have a very grandiose, inflated sense of self-importance. Persecutory delusions then are basically that they believe that they're being punished. Maybe God is punishing them, the FBI is spying on them, the mayor's harassing them, things like that. So they may actually, in rare circumstances, may resort to violence in retaliation for this imagined persecution. Sometimes I even see it to a lesser extent on the unit, where some patients feel that threatened by other patients when really they're not. There's nothing specific going on, but they tend to misinterpret or take some things personally or take things in a different way that it isn't meant, and they can sometimes have great deals of difficulty getting along with other patients on the unit because they feel singled out and persecuted by other people. So this is just a little cartoon that I found, dig fast, kind of a mnemonic, and these are kind of the primary symptoms of a manic attack: distractibility, indiscretion, grandiosity. That's the dig part, and then the fast is flight of ideas, activity increase, sleep deficit, and talkativeness. So just a little way to remember some of the signs and symptoms. And again, another little cartoon that I found just basically shows the manic and the depressive side of the same person. So again, goes through mood, speech, different types of behaviors, decreased need for sleep, things like that, and then the depressive episode, which we haven't really talked about much about the depressive signs and symptoms yet, but this basically gives you a very nice um, kind of a nice outline of some of the main signs and symptoms in bipolar disorder. Little case study discussion. What are some problems that can be avoided if your manic patient gets proper treatment? So I'm hoping that as you're thinking about and looking at some of the symptoms that we were just discussing, that you can think that perhaps that they can avoid some medical problems. You can avoid cardiac issues if your mania is under control. You can avoid perhaps some legal issues. You can avoid relationship issues. You can avoid getting into debt. um, all kinds of things that can be avoided. There's so many problematic behaviors that people have when they have bipolar disorder. Actually, being a productive member of society is absolutely something that we want to promote with patients, and really, if they are getting proper treatment, if they're staying with their medications, counseling, trying to modify their lifestyle to decrease their overall stress level, those can be very, very helpful in helping them to be productive. You might think, well, they're in a manic state and they're so creative and they have all this energy and they only need a couple hours of sleep. They could be getting a lot done, but actually they're not as productive as they think they are usually. So, in rare circumstances, there might be somebody that can actually accomplish some pretty significant things during a manic phase. But honestly, people usually are actually pretty impaired and aren't functioning at their very highest level. So, self-assessment, we always have to think about what is it like to be a nurse working with somebody with bipolar disorder, especially when they're in the manic phase. Because when they're in that phase, they really can have a lot of behaviors that are manipulative. They can be very, very demanding, and they can do a lot of staff splitting. So that makes it very difficult. And as far as the self-assessment, sometimes we have to look at our own feelings when we're working with these patients, and we want to make sure that we are behaving in a way that's therapeutic. Because sometimes they really can push your buttons, and they seem sometimes to have a sense of what is going to really make you upset. So, just a little example, I've seen manic patients even come up to a staff member and say something pretty insulting about their physical appearance. So, commenting on the staff member's weight or commenting perhaps on their grooming. So, a manic patient came up to one of the nursing assistants once and said something like, you really ought to put some makeup on and do your hair before you come to work. So, or they're going to say something about your weight, whether you're heavier or thinner. They're going to say something that's really going to get your goat. And so you have to be aware of that and be kind of expecting it, anticipating it, and plan ahead on how you're going to respond. The other thing they might do is they might just say something just really, really outrageous. They may have outrageous behavior. They may swear. They may just say things in public that are just not appropriate at all. And so that makes it very challenging for us to work with these patients. So we have to think about our own actions, that we have to have frequent staff meetings to deal with patient behavior and staff response. Everybody should really be as consistent as possible when working with these patients. It really does not help them at all if somebody is very lenient and somebody else is really super strict. They need limit setting, but they need it in a very calm, controlled, consistent way. They really don't need people to be kind of, oh, the person's doing well, so we'll give them this privilege. And then the next person comes on the next shift and they're like, no, that's not part of the care plan. And they refuse to do it. And then the patient gets really upset and agitated. When staff are not consistent, you can't blame a patient for getting upset and agitated and acting out, because they're getting different messages from different people. So that consistency is super, super important. And again, just examining your own feelings when you're working with people that are like this, and really making sure that you don't personalize things. So if they say something about your lack of makeup and that you didn't do your hair that day, you just really have to brush that aside and respond just in a very neutral, matter of fact. And you don't even need to respond directly to that statement that they just made to you. That might be the most therapeutic thing. Another really good example is I had a former student a few years ago who was standing up at the desk, and I think she was giving medications to the patient. And this manic patient was very just kind of verbally berating the student. And she was saying things like, "You are the most stupid person I have ever seen in my life. Don't you know anything?" And it was just kind of going on and on and on as the student was trying to give this patient her medications. And the student did a great job of just nodding her head and just saying like, "Uh-huh, uh-huh," and just was nodding her head and listening as she was saying that she was the stupidest person that she's ever met. And she took the medications from her. And every time the student had an interaction with her, she was just very calm and matter of fact and never, ever responded to the insults that she was getting. Well, the next day, the patient was looking for her and she was really happy to have her. So I just think even that aspect of sticking with somebody when they're really displaying difficult behaviors is really important. We don't have to. You can say something like, it really isn't it's not really nice to say things like that to another person. I mean, you can kind of give them some feedback possibly, but honestly, unless they're doing better, they're not really able to take that feedback. They don't get it. They think that whatever they're saying is, perfectly fine. So, yeah, it really is a challenge to communicate. So don't take things personally, and just make sure you always respond in a very professional way, even when they say something just really completely outrageous. The other thing that we really have to think about when communicating with people that have bipolar, especially mania, is that we don't have to respond to everything they say. Try to, again, look for themes. Um, but also, we don't have to drop everything and do everything that they ask you to do. I, again, had a student a few years ago have a patient with who was in a manic state, and the patient was just running the student ragged. Just every time the student had a contact, like the patient would say, "Oh, I need this," and go get me a couple of washcloths. So the student would go get the washcloths, and then the patient would say, "Oh, and now I need a bar of soap." And then the student would run and go get the bar of soap and come back. And then the patient would say, "Oh, and I need some shampoo." And the student would run and get some shampoo and come back. And finally the student kind of said, "Do I have to do everything that she asks me to do?" And I didn't really see this going on. I just kind of found out about it later. Otherwise, I certainly would have stopped her and said, "No, you don't really need to do that." So we don't need to respond to every little request because they can be very, very demanding. It's very therapeutic to set limits and to say that that's part of setting limits too, is to say, I'll meet your needs every half hour. I'll touch base with you if you need anything. Make a list and I'll give all the things that you need to you at one point in time, rather than running back and forth. I think the patient was truly liking all that contact and just kind of, abusing the situation a little bit by having the student just keep running back and forth to grab things. And part of it, certainly, the patient who has mania is not very organized. So they're not going to think, "I need a washcloth, soap, and shampoo for my shower." They're going to think of each thing perhaps separately, impulsively. They're not going to be able to really kind of plan ahead. So that's also part of it. But they really can be very, very demanding, and whatever they want it now, and they have a very hard time with with saying no, with us saying no and trying to set those limits. But it is important that we all work together as a team and take kind of a unified approach in those types of situations. So the other assessment guidelines, we really need to look at their danger to themselves or others. So certainly when people are manic or if they're in the depressive side of bipolar, they can be at risk for suicide. Very, very important that we always assess that. Risk of harm to others, absolutely. They can be very angry, very irritable, and even homicidal towards people in the hospital or people on the outside in their day-to-day life. They can be homicidal towards. So we always need to assess suicidal and homicidal ideation. They need protection from uninhibited behaviors. So if somebody is spending, having affairs, and just going off and sleeping with people without any regard, to anything, if they are making foolish business transactions, or even something like just impulsively going off and traveling somewhere. Maybe they don't even know anybody where they're traveling to. Maybe they're just getting on a plane and buying a ticket and going somewhere to another city, and they really don't even have, any concrete plans. So they need protection from those uninhibited behaviors. Um, the need for hospitalization usually is because of the danger to themselves or others. Sometimes patients are hospitalized in a hypomanic phase, especially if they are known to develop a full-blown mania. So you would definitely need to hospitalize somebody if they are a danger to themselves or others, and they are at that point where if we don't catch the mania quick enough, or the depression too, because depression can spiral out of control and that person can become very suicidal. So really, if they're at either end of the spectrum and their symptoms are starting to get more serious, then they need hospitalization for stabilization. We always need to look at their medical status. It's always important to consider the patient's medical status when we're looking at bipolar disorder. If you look on page, let's see, well, there's like a case study in nursing care plan. Starts on page 232 and ends on page 233. It's kind of a green table, especially on page 233. Really gives you some very, very excellent ideas as far as the interventions to do for patients who are in a manic state and the rationale. And that really highlights looking at their medical status. So we can't just think that okay, this is a whole course on mental illness, mental health, and we can't just say we're just going to look at the psychological aspect of mental health nursing. We really have to look at the physical aspect and the medical status. Some of the illnesses that we're talking about, and this is one of them, where actually the physical status, sometimes some of the abnormalities that can occur can be life-threatening, and that we have to pay very close attention to, maybe even more than their mental status. Eating disorders would be another one. So when we get to Learning Plan 9, there are some real concrete physical aspects to eating disorders that we need to be very careful with and monitor very closely. So that medical status of that diagnosis, anorexia especially, those are anorexia and bulimia are very, very much life-threatening illnesses. Mania can actually be, and depression too, but mania in particular can be a life-threatening illness. So we have to look at their medical status. And again, just really quick, just to kind of highlight that page 233. Did I say 263 before? I hope not. 233. Looking at their proper hydration, nutrition. We have to really watch their caffeine intake. We have to monitor their blood pressure carefully. We have to really make sure that they're sleeping. So all those physical aspects are so important. We should really not be trying not to give them any caffeine at all. Kind of difficult with, the way the hospital policy is, but promoting sleep and just making sure that they are, medically stable is very, very important. So patients can actually collapse from exhaustion. They can have hypertension, again, a huge strain on their heart. So very important for us to monitor their medical status. We always have to look at coexisting medical conditions. Sometimes patients come to us with maybe a pre-existing medical condition. We always have to make sure that we're treating the whole person. Very important to look at the family's understanding. Again, there's on page 237, there's a nice little green table at the bottom, and they talk about what families really need to know. Make sure that they understand that it is chronic and they're going to have different episodes. Really good idea to help them understand that treatment is going to be, it's long term. It's not something that they're just going to get over and they're going to take their medication for 6 months and then they'll be better and they will never have to take medication again. That is just not the way that it is. And also, again, to stress the sleep hygiene and the ability of that person to get a good night's sleep. And that early symptom of a manic episode is lack of sleep. And sometimes you can actually help mania or avert an onset of mania by the use of sleep medications and just helping that person to get the sleep that they need. Coping strategies are important for them. Therapy, it is really helpful for the family too if they can get some information and maybe even get a little bit of therapy to help them to deal with that person because they can be very difficult to deal with. Sometimes patients in the manic state will get very angry and very defensive, and they also can have very limited or no insight into their illness. They don't believe they have an illness, and they really feel I have seen this so many times in patients in the hospital. They just really feel like they don't need medications and there is nothing wrong with them, and they have absolutely zero insight. Those patients are so difficult to treat, and think about how difficult that is for the family member to deal with that person and to live with that person if they don't have any insight into their illness and have no intention of staying compliant to their medications or to therapy. But it really is helpful if the family can try to at least encourage that person to be compliant. So some nursing diagnoses that apply to patients would be risk for injury, again, risk for violence could be other directed or self-directed, and certainly ineffective coping. So outcomes, we always want to, in the acute phase, especially when they're acutely manic, we want to prevent injury. If they were acutely depressed, we certainly want to prevent injury in terms of suicidal or self-harm behavior. The continuation phase, when they're starting to get better, we really want to help them to stabilize and to prevent relapse. So teaching and med compliance again, and also just working on their overall like healthy lifestyle and trying to decrease stress is very important. I know somebody personally that is a young person who has developed bipolar disorder, and she actually had some goals for herself for college, and she had to really change her life goals around quite a bit because college was just too stressful for her. So she is now working in childcare and just really loves it and is thriving and is really doing so much better. So taking away stress sometimes. So you might have to reevaluate and redo your goals in your life based on your illness. So, we do that for medical illnesses too. If somebody has a medical condition and perhaps they have a really bad knee and they wanted to become a nurse, well, maybe now they can't become a nurse because of their knee, so they have to reevaluate and do something different. Same thing with mental illnesses. Um, so again, that relapse prevention, just trying to stay on a nice, steady, calm state if at all possible. It's hard to totally avoid stress, of course, but there are things that we can do sometimes to decrease our stress and to kind of have a more stable life. The maintenance phase then is we want to limit the severity and the duration of future episodes because probably there are going to be future episodes, but at least if we can limit how severe they are. If somebody completely goes off of their medication, they are very likely to again have a full-blown manic episode or a full-blown depressive episode. So if they stay on their medication and maybe notice when they have some subtle changes, maybe they need a med adjustment, then to go to their doctor right away, get that medication adjusted, and maybe kind of limit the severity of that episode, and they're not going to completely fall into a manic or a depressive phase. So in that manic phase, we really have to think about, again, stabilizing them medically, maintaining their safety, and taking care of them in the hospital is certainly most appropriate if they're in that phase. Seclusion, restraint, or ECT may be considered during the acute phase if the patient is truly out of control as far as their behavior. So, seclusion and restraint always should be a last resort. Seclusion is the act of locking somebody into a room and they cannot get out. So you're locked into a seclusion room. Restraints, you all know what restraints are. So usually we think of 4-point leather restraints in a hospital setting. ECT is electroconvulsive therapy or shock therapy. We're going to talk about that a little bit later on in this learning plan, but that's actually a very good treatment for depression. But occasionally, if somebody is in an acute manic phase and they're not coming out of that phase and they are not eating, not sleeping, not drinking fluids, or really physically getting compromised, ECT might actually help to kind of get them out of that initial acute phase. So on page 230 and 231, there's a nice purple table, signs and symptoms, nursing diagnoses, and outcomes for mania. And then on page 231, actually, is the interventions for mania. Absolutely, you should read through that because, yeah, those are absolutely excellent as far as the types of approaches that you use. Firm, brief communication. You certainly don't ever want to be talking and using a lot of words and like loud, loud language with somebody who is manic. We really want to calm ourselves down and use as few words as possible to get things across. So, just go through and read that. It's just absolutely excellent. Talks about communication, structure in a safe milieu, and physiological safety, self care. Absolutely, very, very important things to focus on. Oh, and actually, on page 232, the rest of it, sleep hygiene and elimination interventions are also included. So that's all part of in-hospital nursing care. Do read that over. Those are just excellent bits of information. So, managing medications, sometimes it can be very difficult for people to want to take their medication because when they're in a manic phase, especially if they're in a happy manic phase. Now, some people can be kind of angry and irritable when they're in that manic phase, but some people feel so good and feel so energetic and so happy and on top of the world that they really don't want to take medications because they don't want to feel depressed, especially if they kind of remember what it was like to be in a depressive episode. They really want to avoid that. They don't want to come down from their high. Sometimes they're enjoying it. So it can be very difficult for them to want to take their medications, even in the hospital. They may refuse to take medications. So it is very important to try to do some teaching and encouraging patients to take their meds. Of course, they have a right to refuse, and the only time we could give a medication despite their refusal would be if we have a court order or if they're behaviorally out of control, acutely dangerous to themselves or somebody else. We really want to also decrease their physical activity. There was a young patient once who was in a manic phase, and he was a high school athlete. I think he was a football player or something. So he was a couple years beyond that. He was somewhere in his mid 20s, still looking like he was, in physically pretty good shape and enjoyed that type of activity. And there were times when during his manic phase that he would actually do handsprings down the hallway on 1K. And that really wasn't very helpful. So we don't want somebody doing handsprings and running all over the unit and pacing. We really do want to decrease their physical activity. And I do remember at the time there were some students that really thought it was kind of amusing that he was doing this, and it was a little bit shocking because how many times do you see patients doing handsprings down the hallway? Um, and they really were thinking, well, he's bored. Well, no, he's really not bored. He has mania. This is part of his illness. This is a symptom. So I really had to do a lot of teaching and encouraging the students not to be paying attention to him when he was doing that behavior. So a goal truly is to decrease that physical activity. We don't want people doing that. We don't want them pacing constantly through the whole day and night. We want them to be having food and fluid intake. We want them to sleep. And now it says 4 to 6 hours of sleep per night. Wow, 4 to 6 hours of sleep for me isn't a whole lot. Probably for you either. But I know that sometimes we do that as nurses and students and instructors when we're in clinical and when we're during the school year, during the fall and spring semesters when we're so very busy. So maybe you think 4 to 6 hours is a luxury. To me, that's still not a whole lot. But we really need to make sure that they are getting, actually, we should really be making sure they get a little bit more than that. But to start with, 4 to 6 would be a good goal if they've only been getting 1 to 2 hours of sleep. But of course, we would like them to get more like 7, 8 hours, more of a normal night's sleep. Again, extremely important to their physical health. Just going back to the increasing food and fluid intake, there are times when people are so busy, so manic that they can't even stop to eat. So we have to be very creative sometimes in our interventions. And so there are times when maybe what we can do is um, give them a sandwich that they can eat while they're pacing. So at least, yeah, we'd like them to stop pacing, but if that's the only way to get them to eat, then give them something that they can hold in their hand, some a sandwich, anything that's a fruit that, something that's easy to eat that they can walk around and eat at the same time. They may not be able to actually sit down and eat a tray, eat a meal from a tray. Um, Giving them fluid intake, just really monitoring that. They may not necessarily be on INO specifically, but at least we need to be making sure that they're drinking fluids. Intervening again so that self-care needs are met. Sometimes they may not be getting into the shower, brushing their teeth, doing all those just basic self-care things. So we really have to do a lot of encouragement. So during the depressive episodes, they are likely to be hospitalized for being suicidal, psychotic. They may have a psychotic depression or catatonic signs. Again, being catatonic means basically they're inert. They're not looking at you. Sometimes their eyes are closed. They're not talking to you. They're not responding at all. So we can see this in depressive mood disorders, bipolar depressive disorders, but we also sometimes see this in schizophrenia. So it's a really an interesting symptom, but and not all that usual. But we have seen a few patients that have been catatonic in the hospital, and absolutely they would need care because they are not doing anything for themselves at all. They may not be eating or drinking anything at all if they're in a catatonic state. They may not be voiding. They're certainly not doing any type of bathing or any type of hygiene. So we do have to think about, as nurses, we're giving medications and we're monitoring response to medications. So there are concerns sometimes about bringing on a manic phase when somebody is in a depressive episode. So that is something that we as nurses have to watch really carefully for. I have seen this happen in clinical where a patient who has bipolar is in the depressed phase and they are on antidepressant medications to try to stabilize their mood, but all of a sudden they're getting a little too happy, they're getting a little too high, and we're pushing them out of their depression, but we're pushing them into a manic episode. So we're not the ones prescribing the medications, but we are the ones that are monitoring the effect. And as nurses, we need to make sure that we are documenting and talking to the physician about our concerns if we see that the patient is starting to exhibit some signs of a manic episode. So again, hospitalization for acute mania, bipolar 1, and we have to think about those communication challenges and strategies. So I've mentioned a couple so far, but definitely read. There's a lot of really good information in your textbook too about communicating. Pharmacological interventions. So two main areas that we focus on when we think about medications is the agitation that the patient might be experiencing and of course then their mood stabilization. We don't want them to be either depressed or manic. We really want them to be somewhere in between, more of euthymic, which means kind of like a basic, like a normal type of mood. So lithium is one of the main medications. It's funny because years ago, I started my nursing career in 1981, and lithium was very, very widely used. And then it kind of fell out of favor for a while, and nobody was using lithium. And now it seems to have made a comeback. It truly has always been considered the gold standard for treating mania. And also it does help with the depressive aspect of bipolar also. So truly it targets the symptoms of bipolar disorder. There are some cautions that you have to take though with lithium, and there are some side effects. You can become lithium toxic. You really have to monitor very carefully when patients are on this medication. But it really is the gold standard and a very helpful medication for many people. So the indications are that they have bipolar disorder. There are therapeutic and toxic levels. The therapeutic and toxic levels are actually very close. Now, the levels here on this slide are basically what comes from the textbook, but I hope that you realize that whenever you're looking at any kind of therapeutic blood level, that you have to look at the norms that are calibrated for that specific lab. So I believe the numbers are a little bit different in the Aurora system when we're doing clinical on 1K. So here they're saying therapeutic is 0.8 to 1.4. I'm thinking that's a little bit different from what it is in the hospital. I mean, that's a general ballpark figure. So, and then the toxic level is just very, very a little bit above the therapeutic level. So there's a very narrow range between therapeutic and toxic. So that's the important thing for us to think about as nurses. The other thing is if somebody happens to be elderly on lithium, they can actually be toxic at what might look like a normal therapeutic blood level. So I had a 90-year-old patient a long time ago, and she became lithium toxic, and I know her level was not anywhere near 1.4. It might have been 0.9 or 1.0. It was kind of considered in the normal range, but she was 90 years old and she had developed lithium toxicity. So you have to look at the signs and symptoms of toxicity more than the actual numbers, especially when somebody is a little bit older. The maintenance blood level is about 0.4 to 1.3. But really, again, we as nurses are looking at the patient's behavior at those levels, because if they're at a 0.4 and they're still really manic, they're not sleeping, we need to maybe talk to the physician and see what they want to do about that, like perhaps increase their lithium a bit, because at that, even though they're considered possibly therapeutic, they are perhaps their symptoms are still pretty strong, and that they're not recovering from their mania. Um, Toxicity, we have to be really careful about, because that can be a true emergency. If somebody is lithium toxic, it's possible that they have to go to the intensive care unit for treatment. So, um, toxicity can come on really quickly. And the thing to remember is that we never should be giving lithium unless we know what their lithium level is. I will definitely ask you that in clinical. So remember that. I will always ask you, if you're giving lithium, what is the lithium level? And sometimes we don't have one available because they haven't drawn it yet. If the patient just started lithium the day before, they're not going to do a lithium level because it's going to take a couple of days to develop a level. So that might be the only instance where we don't do a lithium level, but usually we always need to find a level. I can remember one instance in clinical where it wasn't us, it wasn't a student, it was a staff member who ended up giving lithium to a new admission, and without checking the lithium level, and the level came back the next day and it was 2 point something, which is just horrendous. I mean, that person went right up to the ICU, and I believe they had to undergo dialysis. They weren't looking, the nurse was not looking at the symptoms. So some of those symptoms of lithium toxicity would be slurred speech, yeah, just like mine right now, slurred speech, having an ataxic gait, diarrhea. And actually, I'm thinking back, this patient had all of those symptoms. The patient had very garbled speech. He was a middle-aged man, and he was incontinent of stool. There was no physical reason why at his age that he should have been incontinent of stool, but he was. He was stumbling all over. He had the classic signs of lithium toxicity, and nobody recognized that and still gave him his lithium without knowing what the level was. So, he ended up okay, but again, going up to the ICU to undergo dialysis was, a bit not, I'm sure not what he was, not what he was expecting from being in the hospital. There's a table on the top of page 234 in purple, lithium side effects and signs of lithium toxicity. There's a lot of different signs of lithium toxicity besides the couple that I mentioned that this one particular person had. So these are all things for us to be very, very aware of. So page 234 and then page 235, there's another very nice box, 13.1, patient and family teaching about lithium. So you do have a discussion question that deals with lithium. So those are two places that you can really get a lot of your information from. Maintenance therapy, really, there are standard dosages of lithium, but honestly, the physician, of course, prescribes those. It's really up to us to encourage the patient to be compliant. The dosage may really differ depending on the patient's their diet, their usual intake of salt, their usual, their lithium level, and just their ability to kind of maintain that level on whatever dosage of medication they have, and if their symptoms are doing better. So that's as far as the nursing role in maintenance therapy is to encourage compliance and to really to be monitoring the patient's overall mental status in relationship to their lithium. Contraindications. So if patients are pregnant, they should not be taking lithium, or if they're intending to become pregnant, they absolutely should not be taking lithium. So that is very much contraindicated. It also is contraindicated if somebody has a Okay, sorry, I got a little interrupted there. So some contraindications on page 235, right underneath that green table, there's a little paragraph that talks about the contraindications. So basically, in patients with cardiovascular disease, brain damage, renal disease, thyroid disease, or myasthenia gravis, and women who are pregnant, and contraindicated in mothers who are breastfeeding, and in children younger than 12 years old. Case study discussion. Ms. Adams is starting on lithium. Discuss what patient teaching about this medication the nurse should provide before the patient is discharged. Well, again, I just kind of told you 2 pages, 234 and 235, and that is a discussion question. So I do think that it will be very helpful for you to review those tables, and then when you answer the discussion question, that will answer this slide. Anticonvulsant mood stabilizers. These are also used with bipolar disorder. So things that we typically see are valproate or Depakote, carbamazepine or Tegretol, and lamotrigine or Lamictal. So those 3 we very, very commonly see in the clinical setting. So, and at least Depakote and Tegretol also have levels. I have really never seen a Lamictal serum level, but I have seen Depakote and Tegretol. And just a little hint for when you're in clinical, just to know that when you're looking for the Depakote level, it's probably going to say valproic acid or valproate level, or the Tegretol level, it's probably going to say the carbamazepine level. So just to kind of make sure that you, when you're looking up your med information, to kind of know both names, but these are widely used. Second generation antipsychotics are also used if patients are having delusions, sometimes hallucinations or voices, so some of those psychotic symptoms, and of course, like extreme agitation that you can have in mania. So olanzapine, Risperdal, aripiprazole, eseniprine, cariprazine, lurasidone, quetiapine, and ziprasidone, Geodon. So these are all medications that we see in the hospital that are used for, again, people that are having extreme agitation symptoms. It can really help to calm somebody down and, again, decrease some of those psychotic symptoms that sometimes people have when they are in a manic phase. We also sometimes see Thorazine, chlorpromazine, or loxapine. And it says inhaled, that's kind of what the book says, but I have seen loxapine given as a pill in a pill form also for people that have mania, especially when people, and I think these 2 are used especially when people are really having symptoms that don't seem to be responding to anything else, or they really need that agitation decreased, and it helps. They also can help them to sleep a little bit more. when you're using antipsychotic medications, either the first or second generation, we always have to worry about side effects. So with these first generation antipsychotics, we have to think about um, tardive dyskinesia developing long term or extrapyramidal side effects, which we're going to cover more in the Learning Plan 5, I believe it is, which is on schizophrenia. Um, but we do have to worry about those same types of long-term and short-term side effects, that acute dystonic reaction that we can see with Thorazine especially. And then for the second generation antipsychotics, again, we have to worry about the same side effects that we would if a person was taking this for schizophrenia. They might have weight gain, which is sometimes the weight gain is absolutely horrible. It can be up to 100 pounds of weight, extra weight that people are gaining. And that, of course, leads to obesity, insulin resistance, diabetes, and cardiac issues. So we do have to watch people carefully for all those side effects. Some other treatments, ECT. So again, electroconvulsive therapy, kind of mentioned that before. As a possible, I really haven't seen it used all that often for people that are in a manic episode, but I have seen it used on people that are in a depressive episode. And the issues that I've seen a few times in my practice have been if somebody has bipolar disorder and they are in a depressive episode, sometimes ECT, kind of even one treatment, I've seen this happen twice, where a patient will go from very, very depressed to very manic, even in one treatment. So we do, as nurses, we do have to be very careful when we're monitoring patients and make sure we would let the physician know if we see somebody going from depression to full-blown mania after one ECT treatment. So we do have to be a little bit careful of that. Teamwork and safety, of course, is not really a treatment, but is always something that we have to highly consider. And of course, safety, we always think about harm to self or other people. And we have to think about possibly, using seclusion from time to time, although honestly, it is a last ditch resort. We really should not be putting a patient into a locked room or using restraints as a first effort to treat them. What we do with a patient verbally, how we communicate, how we interact and intervene with somebody, and all of the self-care, trying to get them to sleep, trying to get them to take their medication, PRNs if necessary. All those things really can prevent seclusion from happening. Support groups, when people are better and they're able to really discuss their illness, their signs and symptoms, that's the time when a support group can be very helpful. Because people do suffer, even though maybe you think when they're manic, they're happy and they're productive and getting a lot done and they don't want to be depressed, but they don't really like being normal mood either. They really like their high manic mood. So they can really benefit from some support from other people and even problem solving on how to manage different symptoms that they have. And again, we're always doing health teaching and health promotion. Big part of that health teaching and health promotion actually does relate back to their medications, because people sometimes don't take their medications because of the side effects. If they're having weight gain, they don't want to take their medications. And so they do need to be encouraged to comply with their meds, but we also need to do teaching aimed at trying to avoid some of that weight gain, weight reduction and management, and just, again, a general healthy lifestyle overall can be really very helpful. Oh, I think I just actually skipped ahead to the next slide already. Sorry about that. Advanced practice interventions, cognitive behavior therapy, different types of therapies, family focused. So those are things that an advanced practice nurse might do. We're always evaluating outcome criteria and reassessing the care plan and revising the care plan if indicated. So quality improvement, standards for bipolar excellence project. So just an example how quality improvement is used in mental health. So 15 evidence-based performance measures regarding screening, assessment, treatment, and monitoring bipolar, and provides tools for research, teaching, and quality improvement. So just a little bit of CUSIN kind of thrown in every now and then. Audience response questions. Which anticonvulsant medication might be prescribed for a patient with bipolar disorder? divalproic sodium, Depakote, clonazepam, Klonopin, olanzapine or Zyprexa, and lithium or Lithobid. So I am hoping that you picked lithium. And it's not that the other medications can't be used, but they are not anticonvulsant medications. The only one, oh, I'm so sorry. I just gave you the wrong answer. You know what? It's really late at night, and I really should end this pretty soon. Okay, let me start this over again. Which anticonvulsant, you're probably laughing at me by now, which anticonvulsant medication might be prescribed for a patient with bipolar disorder? It is A, divalproic sodium or Depakote. Oh my goodness, I'm tired. Anyways, that is the only one that is considered an anticonvulsant. Clonazepam is a benzodiazepine, olanzapine is a antipsychotic medication, and lithium is kind of in a class by itself. It's an anti-manic medication. Okay, I think it's time to end this this recording, and I'll start again tomorrow morning.